this discussion is going to be based on an article that was just published in the Obesity Pillars and soon will be published in the Osteopathic Family Physician, or at least online on their online portal. And so there's a QR code that you can link to download that article. And what the emphasis was to really develop it was a joint expert review between the Obesity Medicine Association and ACOFP. And the intent here was really to try to identify what are some of the challenges and how to overcome some of the challenges in family medicine. And in this discussion, I will be playing that role as an obesity medicine specialist and give my perspective from it. And Dr. Jeff Pennings will be giving his perspective as a primary care family physician. So these are learning objectives, looking at some of the health benefits of treating obesity, the challenges in family medicine, incorporating lifestyle recommendations, and then prescribing anti-obesity medications in the family medicine setting.
So I'm hoping everyone can just take a second to think about what you know about treating obesity, what you want to know about treating obesity. My hope is that from this lecture today, that what you know about treating obesity we can grow upon, and what you want to know, those questions are answered. And then certainly if they're not, we can answer them along the way or at the end. And then finally, kind of reflecting after this lecture, kind of on what you learned. I think you'll find that obesity and treating obesity is very osteopathic, and really thinking about the body as a unit and everything being interrelated, interconnected, and also the relationship between structure and function. And with obesity, we see metabolic and non-metabolic consequences with obesity. As we treat that, improve the structure, we see improvement in function.
And that's one of the things that really excited me about obesity medicine, was because it is so osteopathic, that I found that as I help people lose weight, I'm taking them off of blood pressure and cholesterol and diabetes medication. And to me, that's what really is creating health.
And when we get to what the why is for this lecture, we've been seeing increasing prevalence of obesity in our patients for the past few decades, with obesity rates over 40% now. And with that, we're seeing a lot of these metabolic consequences. So we think about type 2 diabetes and hypertension and dyslipidemia and so on, very reflective of what we might be seeing day in and day out in family medicine. Obesity also impacts mental health. So higher rates of depression, higher rates of anxiety, as well as eating disorders such as binge eating disorder and night eating syndrome, which is a disorder of compulsive eating at nighttime. So excess calories at nighttime, usually associated with disordered sleep patterns. And then we also see, in addition to some of these metabolic consequences and complications of obesity, some of these non-metabolic conditions, what we call fat mass disease, which is more of a mass effect of obesity affecting the body. So thinking about osteoarthritis, increased pressure on weight-bearing joints, obstructive sleep apnea and acid reflux, increased neck circumference and abdominal circumference, putting pressure and driving those conditions. And then finally, hypertension from compression of renal vasculature driving up blood pressure. And obesity also impacts all-cause mortality. And if you see here, a BMI of 40 to 45 decreases life expectancy by 8 to 10 years. And I think that's a number, in talking with patients, is pretty shocking for them, that they didn't realize that obesity could affect their life expectancy so much. And often that conversation transitions to talking about quality of life too, as patients age and some of these metabolic and non-metabolic conditions progress that can really affect the quality of life at that stage.
So do you see patients with obesity that don't have metabolic abnormalities?
Yeah, and I can think of a patient from early on in residency that this really kind of got set in stone for me. She was in her late 40s. Her BMI was over 40, and I was seeing her as just kind of an annual visit. We checked an A1C and a lipid panel, and I was honestly shocked to see that her A1C was completely normal. It's 4.8, 5%, and her lipid panel was completely normal. And almost to the point that I was do I need to recheck these labs? And in reality, if you looked at how this patient was distributing her body fat, she would have had very little visceral or central adiposity, and much of her body fat would have been peripheral or subcutaneous adiposity, which is not as metabolically consequential. However, she did suffer from struggle with osteoarthritis, obstructive sleep apnea, and hypertension. So it's still important to recognize the connection between obesity and fat mass disease driving some of these other chronic conditions, and talking with patients about, how we can improve obesity and improve some of these chronic conditions.
Right. So not all body fat is the same. Body fat that is located centrally is more likely to cause disease, and body fat that's on the extremities is less likely.
And we can see here, treating obesity will improve structure and improve function. So as we go from 5%, 10%, 15% weight loss, we can see improvement and even reversal of a lot of these metabolic and non-metabolic disease states.
And I think that's, again, one of the exciting things that I find about obesity medicine is being able to reverse those diseases, and even just a 5% weight loss, which, if you weigh 300 pounds and you lose 15 pounds, that may not seem like a lot, but it can be enough. And one of the reasons why that happens is you tend to lose visceral fat first, and that's where you're going to see those improvements. But it's very exciting just to see a patient that has diabetes and be able to reverse it. And so there are different factors that make it difficult to treat obesity in family medicine. There are patient issues. Patients often have stigma and bias towards themselves about their obesity. They may not be aware that their BMI is as high as it is, or understand how it is related and impacting their health. There's lots of different social factors, mental factors that are involved. But there's also a perception of patients that they just should be able to do this on their own, that they don't need medical help. And also with a history of past frustration, having lost weight and regained it. And that often results in a lot of self-judgment for patients when they lose weight and regain weight, and makes them even not want to try or even talk about it, which is important for us as clinicians to be able to ask about it. Stigma and bias also exists in physicians. Still hear of people saying, well, if they just ate less and exercised more, they would not have obesity. And that is true, but why is it so difficult? If that advice is something we've been giving for decades, it hasn't been working. And we need to understand a little bit deeper, recognize that obesity is a disease with metabolic dysfunction and barriers to in losing weight. Looking at the health consequences, and I think we're seeing that more now, that relationship with those health consequences. But how many of you had courses in obesity medicine in medical school? Campbell. Yes, my students. But the only school that offers anything for obesity education. Same in residency programs, it's still very limited, although I see that changing now. And then the challenges of time, cost of medications, and poor reimbursement.
One thing that I, really work on is trying to make sure that I'm not the barrier for a patient having this discussion. And a recent encounter that I can kind of think of that is an example of this is a patient I just saw for an acute care visit. So it wasn't in my patient panel, but was coming in for straining his back after having a recent ground level fall. And I was looking through his chart, I'd seen that he had had a few falls over the last year or two, and that he had class 3 obesity. And as I'm sitting in this appointment with him, I almost had this kind of internal struggle. Like, do I talk to this patient about this? We don't quite know each other yet. Should I wait for maybe another appointment at follow-up and when we've built a little bit more rapport together? As I'm kind of like internally struggling about this, he brings up his concern about his weight and obesity, and said that he thought he had been gaining a lot of weight over last year. He thought it might be contributing to his falls. So kind of just sparked something in me that, gosh, just remember, like, it's probably okay just to ask permission. Do you have an approach for that?
Right. Asking permission is helpful. As I mentioned, patients may be very frustrated and not ready to undertake the effort that it takes to lose weight. It takes a lot of energy. It takes a lot of time. It takes a lot of effort to lose weight, and patients have to be ready for that. So just asking permission, is this okay to talk about? I'm concerned about how your weight is impacting your health, about your diabetes or blood pressure. And I think that if we can approach your weight, that would be helpful. Is that something you're willing to talk about? So that's a kind of approach that lets the patient know that you know this is hard, that you know this is difficult, and that you're showing empathy to the challenge. And I think that can facilitate the conversation. We also want this to be interactive. So if you have questions or comments you'd like to add, please feel free to raise your hand and chime in. But we'll keep going talking about the approach to treating obesity, and it really centers around the 4 pillars that we described: nutritional therapy, physical activity, behavioral modification, medical therapy, which is now includes pharmacotherapy and metabolic and bariatric surgery. And we'll go through each of those, and there are a lot to do in any kind of a visit. But I'd like people to, and I try to train my students and residents to think in those 4 pillars, to learn how to think, where am I going to approach this? Where is it best suited to approach it? So we talk about nutritional therapy, and I like to do a 24-hour dietary recall. Most people are pretty consistent in what they eat, and I find that very helpful. We might zero in on sugar-sweetened beverages or ultra-processed or fast foods. Those are things that people are commonly eating that are contributing to excess calorie consumption. Know what their dietary preferences are. Some past successes are important. Many patients have had success losing weight. It's helpful to have specific dietary plans in your office that we can refer. And it's also important to know that there's not just one dietary intervention that's going to work for everybody. We have to be able to tailor that some. Meal replacements can be used in medical offices. They can be very helpful. And then I often will refer to a registered dietitian. What do you do to approach treating a nutritional approach in your office?
I mean, it can definitely feel like an overwhelming thing to try and cover with the patient. There's so many different factors going on, and patients have individual constraints with where they can move here. But I take a similar approach to what you described here. So I do that 24-hour recall, trying to gather information, these high sugar beverages, ultra processed foods, of areas that I can maybe work with the patient on making a small change that could have a big impact. I really work with the patient on setting SMART goals. I think we all know about SMART goals, and I focus here on the specific and achievable or attainable kind of goals around this. I find that if I have a big discussion with the patient about nutrition, all the different things available to them, and say, take what we just discussed and apply it to your life, those are never the patients that come back having been successful at making a meaningful change. But if I can set a specific and achievable goal, those are the patients that come back excited about, I made this little change, that little change around their nutrition.
And so you don't have to fix everything at once. I think that's really the important message there, trying to target the areas that are going to have the biggest impact. We also look at physical activity. So looking at what is a patient's motivation for exercise. I always say that when people ask me what's the best exercise for somebody to do, it's the one you'll do every day. The key is to be moving and identify what would the patient like to do, and what are their limitations? Do they have any issues with arthritis that might be limiting them? And I'll write an exercise prescription using that FIT model. Is that something that you've used with your patients?
Yeah, I find exercise prescriptions helpful. I take a similar approach to what I do with nutritional therapy. So I lean into those SMART goals and leaning into the specific and attainable, and really let the patient lead with, what their interests are and, what they could realistically do in their life. Because if they kind of lead that, and then my job as a physician is to guide them, okay, let's make a specific goal around that, and let's make an attainable goal around that. Those patients are more successful.
And so FIT stands for frequency, intensity, type, time, and enjoyment. And I use this prescription and I ask the patient, what are you interested in doing? What are you willing to do? And I actually first ask them, are they interested in increasing their physical activity? Then what are they interested in doing? How often can they do it? How intensely can they do it? And then how much time can they spend on it? What I do is I circle each one of these as I'm asking the patient these questions, and then what can they do to make it fun? And that is really important. So some patients will like to listen to music or watch shows or things like that. But by having the patient tell me what they're going to do and writing it down, for them, they own the goal. And I find that they're more likely to do it if they're setting the goal and owning it. And typically, if a patient even says, I'm just going to walk 5 minutes a day, and that's, obviously not enough to have a meaningful impact, but I'm okay with that, because what I find, since they own the goal, they come back and say, well, I walked 5 minutes, now I'm up to 10. They start upping the goal because they own it. And so I find that very helpful. But strength training and then something called non-exercise activity time or NEAT time, looking for those simple things, people parking further away, taking the stairs rather than the elevator. Those are setting step goals or simple ways to expand that. So the next pillar is behavior, and this is really the why people eat, and why is such an important driver. And it's often the thing that gets them off course, that they're doing fine, but something emotional happens. They have an argument with somebody, they have a stressful day at work, that triggers the eating. So understanding those emotional triggers is really important. Clean plate mentality is also something that I think we all grow up with. Who heard you have to clean your plate before you can have dessert? Mm-hmm. There's children starving someplace in the world that making you feel guilty. What are you teaching a child? You're teaching a child to eat past the point of fullness. You're teaching them to disconnect from their normal appetite regulation and just consuming all the food that's in front of them. And then sleep is also a very important component. Which of those do you tend to focus on, Jack?
I'm using this to really identify, like you're describing, patterns in a patient's eating, because that might help me target what medication I might choose if we go that route. And then also barriers that they might face or they may have previously faced with past journeys with weight loss. So really looking for those patterns and those barriers to help them be more successful in this journey. And then this is another area that I'm using our behavioral health team to meet with our patients and talk to them about accountability and goal setting, to talk to them about alternative things to kind of turn to when they're feeling emotional stress, if they do identify as being an emotional eater, to kind of help with coping with those times. And then also, if we're thinking about the spectrum of obesity, poor sleep hygiene is a big contributor to that. So using our behavioral health team to kind of help with CBTI and sleep education.
And I think tapping into your support, whether it be a registered dietitian, an exercise physiologist, a behavioral therapist, really is important for managing obesity. And so the fourth pillar includes medical therapy, which would be anti-obesity medications. And the important thing is to understand, why do we use anti-obesity medications? Why are they important? And as I discussed in my other lecture, if you were there, it is a complex process that regulates our appetite. It's not conscious decision making. It's not willful effort. It is these internal signaling in our body that stimulate or activate the hypothalamus to be able to increase appetite or decrease appetite. And so when we go into a negative energy balance, when we eat less and we are exercising more, our body is going to respond to that by increasing hunger signals, decreasing satiety signals, and making it difficult to sustain. And so the anti-obesity medications counter these responses. But also what we're seeing now is the role of anti-obesity medications in the treatment of other conditions that are obesity related. So cardiovascular disease and obstructive sleep apnea now both have anti-obesity medication indications for treatment. And I see a number of these in the pipeline, whether it be osteoarthritis, heart failure with preserved ejection fraction, fatty liver disease. These are all things that we'll see as likely in future indications for use of these medications. How do you approach that?
Much the same. I think we're in an exciting time for treatment of obesity, that there's more options for patients and for physicians to help patients navigate this. In the past, when we're really leaning just into lifestyle interventions, we frequently hear that story of past successes and then regaining weight 6 months later, 12 months later. And with the emergence of bariatric procedures and anti-obesity medications, finding ways for patients to be more successful with this and reversing obesity.
And so I showed this in the other lecture as well, because this is really a message I want you to take home with you, that this is a struggle, and it's a progressive struggle, that as individuals lose weight, those hunger signals get stronger, and they get more persistent. And that's reflective of this spring. So this person, as they're losing weight, as they're engaged in diet and activity, that spring is pulling them backwards. And the more progress they make, the stronger that spring is going to pull them back. And that is metabolic adaptation. That is those changes in appetite hormones. That is the decrease in metabolism that naturally occurs as we lose weight. Our resting metabolic rate goes down. And muscle efficiency, which is how efficient our muscles are at burning calories. And this is a situation where we don't want them to be efficient, right? We want them to be inefficient so that they are going to burn more calories. And so the anti-obesity medications are really hitting specific targets with respect to that. We see the hypothalamus and limbic system and gastric emptying being impacted by the GLP-1 agonists, that they're working centrally within the brain, but also in the reward pathways to help decrease appetite. We see the other approved medications, the phentermine, topiramate, bupropion, naltrexone, also working on both reward pathways and appetite suppression. And then there's a lipase inhibitor, orlistat, which is not really used very often because it doesn't have great results.
So you can, look at, again, some of these patterns in someone's eating and target maybe a medication that you think they might be more successful with. So if a patient describes more of this insatiable hunger, this food noise, maybe phentermine in combination with or without topiramate is a good option for them, an appetite suppressant. But if a patient identifies that maybe they are leaning more into this reward center around food and emotional eating, maybe bupropion and naltrexone in combination would be a better combination. And then if we're thinking about patients that have more of these comorbidities and metabolic complications with their obesity, thinking diabetes and cardiovascular disease, or patients that need to lose more weight to reverse their obesity, maybe we're leaning into more of these newer medications, the GLP-1s and tirzepatide.
So you can really tailor your treatment according to what those patient history is, what their drivers of consumption are, and be able to modify therapy there. And so then the next pillar is using metabolic and bariatric surgeries. And one of the things I want to bring out is that there was a recent change in the recommendations of who qualifies for bariatric surgery. So it used to be that anybody with a BMI over 40 or 35 with one adiposity-related disease would qualify. The American Society of Metabolic and Bariatric Surgeons recently came out with a change in recommendation, lowering that to 35 for anyone that has a BMI of 35, and anyone over 30 that has type 2 diabetes or some other medical adiposity-related disease that hasn't been responding to therapy. Now, not all insurance companies have accepted those new guidelines, but those were recent recommendations. Also, to understand that metabolic disease occurs at lower BMIs in Asian populations, so they have a lower threshold for that. And then these are the recommendations for adolescents undergoing bariatric surgery, which is certainly more common than it used to be. So metabolic and bariatric surgery, and that the metabolic component is a recent addition to that. The metabolic component is a reflection of how it not only just changes the size of the stomach and the ability to absorb nutrients, but also affects the metabolic regulators of appetite. So if you do a gastric sleeve, you're going to remove a large portion of the stomach. You make less ghrelin, which is a hunger hormone. When you do a bypass, you're shortening the transit time from mouth to small intestine, which is going to activate GLP-1, GIP, and a host of other agents. And so you're getting a metabolic response there. Age is not a consideration to do it. It's more frailty in how frail someone is if they're older. And there isn't a restriction around puberty that there used to be a perception that we wouldn't do metabolic and bariatric surgery till after somebody had gone through puberty, and that's not a requirement anymore. And I think one of other things I'd like to point out is just how many benefits that you see as a result of the surgeries, that we're really seeing a big change in their health parameters. So was metabolic and bariatric surgery something that you refer to much in your practice?
Honestly, not a tremendous amount. In Boise, we have, I think, a 2-year wait list right now for bariatric procedures. And often I'm thinking about, the spectrum of treatment of obesity and bariatric procedures being for, patients that, certainly are beyond deep in class 3 obesity, and trying a kind of a step up approach for a lot of patients.
And so there's another concept called the weight prioritized visit. Because it is a complex condition, because you're managing so many other things at the same time, instead of trying to add obesity into the mix of all the other things that you're managing, there's a concept of using a weight prioritized visit where you are having a visit specifically with that patient to discuss and address the treatment, to address obesity and come up with a treatment plan. And if you're going to do that, there are some things that can help streamline that by optimizing your EHR and putting in some questionnaires as well as order sets, working with your staff to be able to collect that data, and also making sure that they're not engaging in things that make the patient feel stigmatized is important, like weighing somebody in the middle of a hallway. That often can be something that turns patients off. But being able to incorporate that and then also engaging your patients. So, Jeff, is a prioritized visit something that you do in your practice?
It is something that I'm really hoping to work into what we call our NAPA comprehensive care clinic. So at our residency program, we have 2 half days per month where we have residents working partnered with an attending. It's a resident, usually a medical student, as well as a behavioral health provider and a pharmacist that are working in areas of family medicine that they might not see every day in their continuity clinic. So we'll do Suboxone induction, gender affirming care, and hepatitis C treatment and management in that clinic to give residents more experience in those areas of medicine, also kind of meet a need in our community. And so this is something that I think would fit really well into that model because we have behavioral health there, we have pharmacy there, and we could add our nutrition team to that, and really adding a service for our patients and making sure that we get to treat obesity in kind of all realms of it, across the full spectrum of it.
So having that more comprehensive visit and just focused on that and making sure the patient is clear that that's what the visit is for.
Right.
So we have a bunch of cases here. We actually will plan on going through the first 3 of them. We have a couple additional ones for you to review independently. But before we go on to that, are there any questions or comments or anything? Yes. There's a microphone coming to you, so you'll be able to.
Oh, I just want to make a comment. As we're discussing obesity with our patients, I think it's extremely important to set realistic goals as we come up with that treatment plan, because oftentimes patients' expectations are just totally unrealistic. Then they become frustrated and they lose that desire to keep going. So I just wanted to add that to the comments that were already made, setting realistic expectations being so important.
Absolutely. I agree 100%. How do you manage expectations?
I think the more time that we can spend, like you're saying, having a weight prioritized visit, the more likely we are to not miss things like that. But I think as I'm talking to patients, and we'll get to it in, I think, a different part of the lecture, as I'm talking to patients about what treatment approach we might take and what they're interested in pursuing, we do kind of break down, what we might anticipate with this singular approach or this, adding lifestyle modification to pharmacotherapy and thinking about the individual agent that we use. So I'll set expectations around that, with the information I have, from randomized control trials on what to anticipate patient to patient. But we'll find that some patients don't lose what the randomized control trial states, and some patients lose more than that, which we'll see in this first case.
Right. And so that is, I think, important. And patients will ask me, what should I weigh? And I don't know. I don't really have an answer for that. What I do tell them, though, is that when you're losing weight, your body is going to hit a plateau at some point. We need to listen to our body. They'll pick a number. It typically ends in 0. And that just shows you that it's random. Does our body want to be at some number ends in 0? That shows you how random it tends to be. So I think it's important that we work with the patient to help them optimize their diet and their physical activity and see where that takes them in terms of weight.
So usually we talk about nutrition and physical activity, but what I find in my practice is that I first need to address the food noise first, and those patients tend to be more successful than the one that I try to do the whole nutrition and behavioral therapy first and then go into the pharmacological agents. Did you have any similar experience?
So how would you approach?
Food noise is a common thing that we'll hear. And a common thing that we hear, if we might choose phentermine for a patient is like, I feel so great on this medication. I don't have that food noise anymore. And that was something kind of new to me, kind of as I've, expanded, obesity treatment in my practice. This concept of food noise and how it can be shut off and how much better patients can do. But I totally agree that that is, important thing to address with patients. They don't even know where to start until they can get that under control.
And it's often a give and take as to what are they ready to work on, what are they feel is most important, and being able to work with them through that process to be able to prioritize the things that are most important to them and the things that are most likely to change.
Hello.
Hi.
So, one of the biggest challenges that I face is maybe lack of access to the medication. And please correct me if I'm wrong or if I'm doing the wrong thing, but I usually pick the medication. I guess when I say it out loud, it makes sense, but I pick the medication that's easiest for the patient to attain in terms of cost effectiveness, but not always the best one for them. Because I work at an organization where many of the patients are under a certain insurance plan that literally stopped covering GLP-1 agonists. So a lot of them are now self-pay, and not everybody is going to pay $400 to $600 a month for the medication. So that's one thing. So if you have any insight on that. And then number 2, the alternative medications that are the oral meds like phentermine, topiramate, I was under the impression that these are not good to be used long term. So my patients whose BMI is like 40 or 50, where they have a significant amount of weight to lose, and it's only like 4.5 or 4 to 5% of their total weight, it's like you lose maybe 20 pounds and then you stop the medication and then you gain it back and your BMI is still in the class 3 range. So it's not advisable. So I just get kind of stuck and a little bit discouraged when I know that they could be getting a lot more benefit, but the cost of the medication is something that they cannot avoid. So if you have any insight or anything to help me, please.
I'll let this one kind of ties closer to your case.
Yes, and so we'll kind of touch upon that on the case. But for one, the short-term use of phentermine is not going to get you to your goal. We don't, and it's kind of specific to phentermine that is an issue, and that's changing. In Ohio, it used to be a crime to prescribe phentermine more than 12 weeks, like literally jail time kind of thing. But that was an extreme case, and it's changing, right? So the laws have changed there, and they've changed in a lot of areas as we come to recognize that obesity is a chronic disease and needs chronic treatment. I'm in North Carolina. The North Carolina Medical Board actually had a position statement against using long-term use of phentermine. I actually appealed to them, to their policy committee, presented a white paper. I gathered the expertise of physicians around the state, and they got rid of that policy. They said, we're just going to treat according to the standards of care. So there's no restriction on the use of phentermine as long as you're using it appropriately. And so it's important that you know what your state board says, and it's important to know what your state pharmacy board says so that you're not violating any of your state laws. And if those state laws provide restrictions, I encourage you to advocate for change. But I do use it long term, and it's the studies that look at long term use have shown it to be have not shown increased cardiovascular risk or any complications there. Yes.
Concerning dosing schedules for the GLP medicines, I've kind of seen two main strategies, either just slowly increasing and kind of seeing where the patient plateaus and then going up to the next dose and waiting to plateau and increasing like that as tolerated, versus kind of more of a sprint where I see them every single month, and every single month I see them, I increase it until they're all the way at max and then kind of see what happens or back off if side effects start to occur. So do you have one that you've either found anecdotally works better, or is there any research that would back up one or the other strategies?
So when semaglutide was first approved, the requirement was they had to get to 2.4, or insurance companies wouldn't even cover it. Then they backed down to 1.7. And so I'm typically titrating up to that dose. Now I've had patients on lower doses have their appetite fully suppressed. And that's really what I'm listening to. I'm listening, what is their appetite, right? Are they hungry? Are they not hungry? And if they're not hungry, I don't increase the dose. Now, that can sometimes pose a challenge for the insurance companies. For tirzepatides, it's a little different. The maintenance dose is 5, 10, or 15. And so there's a little more flexibility there. But if a patient doesn't need to fully titrate to 1.7, I'll keep them at a lower dose. And if I have to, argue with the insurance company, I'll do that.
You might have a case on this, pediatric patients, and maybe this you can put off. But I have a great speech for adults, but I struggle a lot with addressing obesity in kids, especially in teenagers and teenage girls, how to kind of bring it up without being shameful, I try to address it with my little kids is like, we want you to be as healthy as possible. But like the teenagers catch on and they know exactly what you're talking about. So I don't know if you have any thoughts about the best way to bring it up in that population, specifically teenagers, who may be already feeling the social effects of being overweight.
Okay.
So we will cover that with the third case. So I might transition us to get moving into the first case, and then that is our third case.
Yeah, but it's a great point. It's a great challenge. All right, so this is our first case, 40-year-old white female, class 2 obesity. I'm not going to read the whole thing, but I'm going to highlight certain things in her history that I think stand out. She would overeat to ease her hunger. She would eat vegetables and protein, but still be hungry. Her appetite increased after having her second child. She finds herself just eating more, larger portions, and she snacks throughout the day. So what do you see? What are you hearing in this particular patient?
That she's hungry all the time. That maybe she has that food noise that you were describing.
Right. And so this is a patient that is what we sometimes call hungry brain, that is driving her consumption. So looking at her past history, I'm going to highlight a few other things. She's got chronic back pain. She's also had back surgery, and she takes gabapentin, 300 milligram pills at HS. And so what would concern you about that history?
With the gabapentin, that is a super commonly prescribed medication that is associated with weight gain. So commonly I am looking through patients' medication lists and trying to identify, what medications they are on that could be driving obesity, as well as what are their chronic conditions that might be related to that fat mass disease. So chronic pain, some of her past orthopedic surgeries. So she might already have some limitations in her mobility related to this.
And so these are medications that are commonly prescribed, most commonly prescribed medications that are associated with weight gain. They don't necessarily cause the most weight gain, but they're most commonly surprised. And I'm sure there's a few things that may stand out to you, like metoprolol or atenolol, that beta blockers are associated with weight gain. Gabapentin is commonly prescribed. Prednisone, the SSRIs, insulin, and sulfonylureas are associated with weight gain. And diphenhydramine, which many people are taking at night for sleep, is also associated with weight gain. And so we want to look for options that are not weight promoting. So bupropion would be preferred over the SSRIs. And if you have to choose an SSRI, the fluoxetine and sertraline tend to be better. For the anti-seizure medications, topiramate and zonisamide, these are also medications that often help with chronic pain. They don't have as much data as pregabalin or gabapentin, but in my experience, they've worked very well. Any others that kind of stand out to you?
Still working on an inpatient, so seeing new AFib exacerbations, heart failure exacerbations, and commonly seeing patients on metoprolol that have class 1 obesity or higher. And talking with cardiology, could we switch them to carvedilol, more of a weight neutral medication than with metoprolol, and making little interventions like that.
Great. And then looking for those medications that promote weight loss for the treatment of diabetes. So our patient here we see is a BMI of 35, which is class 2 obesity. She has central adiposity. She also has, so her BMI 35, chronic low back pain, migraine, headaches. And so what I did with her was we take that 4-pillar approach to that. She was on Weight Watchers before. She wanted to resume Weight Watchers, but I was going to refer her to a registered dietitian as well. She was going to continue walking, starting, and also she hadn't been doing her back exercises, so she's going to start doing those. We worked with some mindfulness therapies to try to be more conscious of why are you eating? Many times people are eating out of boredom or out of social reasons, and they're not eating out of hunger. Being in tune to that, managing a portion control, and then I put her on phentermine, which is very helpful for that hungry brain. 37.5 milligrams, just a half a tablet, and I typically use that lower dose. And then we were transitioning her off of gabapentin and onto topiramate. So she cut one of those 300 milligram pills every evening over a week, and then took a 25 milligrams topiramate. So we stepped down on a weekly basis until she transitioned off the gabapentin and onto topiramate at 100 milligrams. And we talk about surgery because she qualifies for surgery based on the new standards, but she was not interested in that. So phentermine is one of 3 medications that is approved for long-term use. It's been around since 1959, so it certainly has a long history and track record. It comes in different dosing, short-acting and long-acting doses. It's a central acting sympathomimetic, and it helps to decrease hunger within the brain. It has some anticholinergic side effects, so glaucoma is a contraindication and some cardiovascular side effects, so we would look to avoid in patients with known cardiovascular disease and uncontrolled hypertension. The anticholinergic effects are usually the adverse reactions that we see with dry mouth, constipation, also increased heart rate and blood pressure, so we want to monitor that. And average weight loss is about 7%. And it is controlled substance. Is this something that you use in your practice?
Yes, and I typically will prescribe the 37.5 milligram tablet, the scored tablet, because it is really cheap. So even if they are underinsured, they can, I think, fill it for under $20. But I typically start them on a half tablet of that. But how do you usually decide if you're going to increase their dose and when you increase their dose?
Yeah, I tend to stay with the 15th half of a 37.5 milligram, one of those doses, because it usually is sufficient. That high dose is more likely to cause side effects, doesn't necessarily add a lot to the appetite suppression. Now, I do increase it in some patients that are feeling very hungry, but listen to the patient. If the patient says this is working for me, I leave it at that dose, and I find that it can work quite well for patients at that dose. So it comes in combination with topiramate in an extended release form. Same indications that all anti-obesity medications have. BMI greater than 30 or 27 in an adiposity-related disease. Typically, you titrate this dose up to, you keep them on a low dose for 14 days and then go up to the 7.5, 46 milligrams and see how they do. Do they lose at least 3% of their body weight? Are they hungry or not? Is it effective for their appetite? And then I would titrate upward if I need to. Topiramate also works centrally to decrease appetite, and topiramate tends to work well for nighttime eating. And that's why I think these two complement each other so well, because the phentermine is dosed to be released over the course of the day because it can interfere with sleep if you take it too late. And the topiramate tends to help with the nighttime eating, the nighttime cravings. And so I find that beneficial. You see the contraindications, same contraindications, and adverse reactions. Weight loss is about 10%. But one other thing that's unique about this is it's subject to REMS, risk evaluation and mitigation strategy. So you should be doing pregnancy tests in your women of reproductive age. And so just a little bit about coding, because coding has changed this year, that there are new codes. So for this patient, I would be using that obesity code, and I will be also using the BMI code. And so you can see here she has a BMI of 35, so she would have class 2 obesity, which is E66.821. We don't use the E6601 because it's very judgmental. Morbid obesity due to excess calories. And then we use the Z code. And you can see the list of Z codes, which is just the BMI, is Z68 plus the BMI until you get above 40, and then it changes.
Yeah, I came across a recommendation for your phentermine-based medications to do a pregnancy test every month.
So you have to follow what the package insert says, and that's usually what they recommend. And so that they do monthly pregnancy tests, that they use at least that they use 2 forms of contraception.
Do you have like a standing order for them to come in, or do you have them come in? Do you have a standing order for them to come in once a month for that, or do they do it at home, or a nurse only visit?
Usually would have them come in. They can do it as a regular order.
Okay. So, and it's just the phentermine, not the Topamax portion.
No, it's the topiramate component. Topiramate is associated with cleft palate deformity, so we use that for the topiramate component.
Thank you.
All right. So to follow up, at 2 months, our patient had lost 27 pounds. So 12.5%. So it really was very effective for her. It really took away that hunger drive. Her migraines had resolved with the topiramate because that's one of the uses that we have for it. And she was still having some back pain, but she was able to eat a smaller portion. She was walking with a coworker, and stopped snacking. So we increased the topiramate because her back pain was still bothering her. And this was her course. So she had lost 58 pounds, over the course of, this was about 6 months, with this combination. And her BMI was now down to 26.7. So how would you manage medications from here?
So at some point I would, consider talk to the patient about considering stopping the phentermine at least. The topiramate seems like it's helping with her back pain and her migraines. And yeah, it's interesting to learn from you that you'll have an approach that sometimes you'll have patients kind of identify when they struggle the most. So is it when they go on vacation? Is it on the weekends? Is it during the weekdays? Around the holidays, and actually having the patients start the medication again around those periods of time and just intermittently take it. So that might be approach. We know that if we stop this medication, that food noise is very likely to come back. Maybe not as strong, but it's likely to come back. And so they're going to be more likely to unless they've really adopted significant lifestyle changes, they're going to be likely to start to regain that weight. So having options available for them to go back on medication, even if it's not full time, can be beneficial for them for maintenance.
And the topiramate may be sufficient. And so sometimes I will use phentermine on a PRN basis. So if they're doing well with it, they're not very hungry, I would say, if you're struggling on the weekends, then take it on the weekends. That we don't have patients go through withdrawal. We don't see any issues around that. So being able to go on and off of it is something that I've been able to do successfully. I'm not sure where the microphone is. Oh.
Hi, my name is Jorge. I practice family medicine, and I had a question for you guys. So I recently started working for a big institution and acquired many patients from another physician, right? One of my patients, BMI 21, has been taking phentermine for like years because she was anxious that she was going to develop obesity from, due to a family history of obesity. No signs of like type 2 diabetes, no signs of high cholesterol, just a young gal with a BMI 21 with...
Yeah, I can't really endorse that.
Right. So how would you, like from your expertise, how would you be approaching this topic with someone that is very anxious to be gaining weight over a long period of time?
And so I manage hunger, right? And I would ask her, is she hungry? Is she struggling with her appetite? If she doesn't take the medication, does she have a big increase in her appetite and gain weight? So if she doesn't, then I would start scaling back the medication, decreasing the dose, maybe decreasing the frequency with which she takes it, and ease back. And then again, see, does her weight start going up? Does her appetite go up? Is she going to regain weight? And then perhaps dose it accordingly.
I think in that scenario, if she never met criteria to start, for like indication, it's certainly hard to continue that. So talking about tapering off of it, I think would be a good idea.
Yeah, and that is key, right? It was never justified to begin with, so that is a big question mark. I would never start it in that situation. But you inherit things that you don't control, right?
We have another question. It looks like there are a couple.
Yeah. Besides moving to France and getting a lower price for the weight loss drugs as an option, what do you think about this balloon that you swallow? It expands and then it collapses after 4 months, and this says it costs like $4,800. I mean, what do you think about that as an alternative to some of these shots?
So the endoscopic procedures are something that's gaining more attention and a potential benefit as a bridge, to help patients get to a lower weight, but not something I use, not something I really found to be terribly helpful because it doesn't really create a long-term approach. And so you'd have to have something that you would transition to then. Okay, I think why don't we keep going?
So for case number 2, this is a patient of mine, a 34-year-old male that presented history of generalized anxiety disorder and was coming to me as a new patient, comprehensive physical exam. His vitals of that appointment were blood pressure of 136/90. His weight was 252 pounds. His BMI is 34. Waist circumference 46 inches, and physical exam consisting with or concerning for central adiposity. He came to me with some labs that he had gotten before that visit, which showed a fasting glucose of 110, AST of 50, ALT of 84, lipid panel of 35, and LDL 141. Triglycerides were 321. So from this, is there concerns that you have for this?
Right,
case?
certainly, a lot of metabolic dysfunction there, right? Elevated glucose, elevated blood pressure. ALT greater than AST, which is a marker of fatty liver disease, typically patients that have metabolic dysfunction associated steatotic liver disease, or what was previously called NAFLD, is a AST being higher, ALT being higher is a marker of that. And then high triglycerides, low HDL, that's certainly concerning.
And that's a lot of what we talked about during this visit. So he came in with this anxiety diagnosis and kind of left with a few new diagnoses. So class 1 obesity, metabolic syndrome, which he met all 5 criteria for, possible MASLs, elevated blood pressure without diagnosis of hypertension. And he recognized that there's probably some things in his lifestyle around physical activity and nutrition that he could really work on that were probably driving this. So we made a plan to order some additional labs, an A1C, a fasting insulin, iron studies, and a chronic hepatitis panel. Those labs came back with a glucose of 89, a hemoglobin A1C of 5.2, fasting insulin of 26.5, and his Hep B and C panels were normal and his iron studies were normal. So what sticks out to you, for these labs?
Right. So the glucose now is normal, A1C is normal, but the insulin level, why is that concerning?
So I chose to draw a fasting insulin level on him because of that dyslipidemia I was seeing, because of the elevated liver function test that I was seeing in that initial visit. I was really concerned for significant metabolic dysfunction for this patient. And I'd say this patient and this case is like a perfect representation of how much my practice for patients very similar to this has changed as I've gone on through residency and on into attendinghood. So I would say early on in residency, I would have saw this patient, even if his A1C had been like 5.8, I would have said, you got to work on your lipid panel. Let's work on some exercise. You're not a diabetic. Work on some nutritional changes, and let's see you back in a year and repeat that A1C. And in reality, there's a lot of metabolic consequences going on right now related to his obesity, and it's important to recognize that and intervene now. His HOMA insulin resistance value there, 5.8, is elevated, consistent or concerning for insulin resistance. So that's a calculator you can use through MD-Calc. There's other resources to use for HOMA calculators. If the values, you plug in a fasting insulin, fasting glucose, and the values above 2, that's concerning for insulin resistance. I discussed this with the patient. He was really motivated to continue with these exercise and nutritional changes that he had made, and we made plans to follow up labs at his next visit.
So how does insulin resistance cause hyperglycemia?
And I think it's important to take a step back here and dive a little bit into the physiology of what's going on here with insulin resistance. So under normal physiology, insulin moves glucose into cells for energy and storage. Insulin is also important for storing fat and inhibiting the breakdown of fat. And when patients develop insulin resistance, the body transports and uses glucose less efficiently, and the body becomes desensitized to this inhibition of lipolysis, or the breakdown of fats. And that's what's going on with insulin resistance. So if you look here on the left, excess calories driving hyperglycemia, excess glucocorticoid receptors increasing cortisol, which is going to increase visceral fat deposits. It's going to further increase glucose. And then excess beta-3 adrenoreceptors are going to increase lipolysis, or the breakdown of fats. All this in combination is going to increase free fatty acids circulating through the body, which is really problematic because that's going to cause oxidative stress throughout the body. So at the liver level, this is affecting glucose storage. This is affecting our ability to store and process fats, and driving that dyslipidemia. At the muscular level, we're seeing muscle damage, including to the heart, driving cardiovascular disease. The pancreas is working less efficiently, and beta cells start to die off. And then finally, adipose tissue starts to increase lipolysis. So that makes more free fatty acids circulating, and starts this vicious cycle of inflammation and oxidative stress throughout the body.
And so that increased lipolysis is going to be also releasing more free fatty acids. So it's a two-way street where you're going to see an increased production of free fatty acids as a consequence to this. So how is it impacting the lipids?
if we look at the liver more specifically, we talked about how the liver is going to store glucose less efficiently, and it really affects our liver's ability to process and store fat. So what's going to happen, increased free fatty acids are going to result in increased VLDL levels. VLDL is primarily made of triglycerides. Some of those triglycerides stay in the liver and are stored as fatty deposits, driving fatty liver disease. And then some of that liver in our body's attempt to process this increased VLDL is going to kind of sacrifice our HDL. So HDL levels go down. So our cardioprotective lipid is going to go down. And then LDL number goes up. And LDL particle size, they become smaller and more dense, which is a more atherogenic state. And this is why, you can look at that patient and other patients' lipid panel and be like, oh my gosh, I'm really worried about insulin resistance and the trajectory to diabetes by looking at that lipid panel and seeing high triglycerides, low HDL kind of a pattern.
And not all that fat leaves the liver, right?
Yeah, and those triglycerides deposited in the fat driving steatosis.
And so what's the process of going from insulin resistance to type 2 diabetes?
So this is an important pattern to recognize. So insulin resistance precedes a type 2 diabetes diagnosis typically by 10 to 15 years. So I really try and predict kind of where my patient's at in this trajectory. And this is a picture that I'll kind of draw for patients in our visits when they're in this metabolic dysfunction state or in this prediabetes state. So if we look back, I don't think it's going to point, but our patient is somewhere around here. His fasting glucose is roughly in the 90s to 100. So his blood glucose level actually looks okay, but you can see his insulin levels, insulin resistance is significantly elevated, and his beta cells are hyperfunctioning. And at some point, that insulin resistance becomes too intense. The beta cells can't keep up, and they start to fail. So we'll start to see as the beta cells fail and insulin resistance continues to rise, that the blood glucose will progressively rise until they reach a type 2 diabetic state. So again, this case for me, I'm like, this prediabetes state, or even before that, when you're seeing early signs of insulin resistance and metabolic dysfunction, is the time to make significant change and prevent all that damage and oxidative stress that we were describing before.
And typically by the time a patient gets to type 2 diabetes, meets the diagnostic criteria for it, half of their pancreas is burned out. So we're really coming in at a late stage, not at an early stage when a patient is first diagnosed.
And this is not like to put patients that do go on and develop type 2 diabetes in a state where they need to be in complete panic, because, the reality is our agents with the GLP-1s and SGLT2s are so much better at reversing insulin resistance, helping with weight loss, cardiovascular protection, renovascular protection, cerebral vascular protection. Patients have a lot more options to put their diabetes into a better controlled state and into more of a remission than they used to. So at our follow-up visit, the patient had adopted these lifestyle changes and was really doing well. They'd lost 15 pounds. His blood pressure had improved. And he was reporting that he was feeling better, getting better sleep. And we were starting to see incremental improvements in his lipid panel and his metabolic panel. His diagnoses stay much the same. I congratulated him on the hard work he was doing. He really wanted to stick with more of a non-pharmacologic approach to his treatment plan and didn't want to see nutrition at this point. So we made a plan to continue on with the lifestyle changes and see him back in 3 to 6 months. Fortunately, at his next visit, he regained that weight back, reporting difficulty with maintaining his lifestyle changes. And we were starting to see kind of worsening again of his lipid panel and his metabolic panel with a rise in his ALT. So for this, he still was a little bit resistant of escalating his therapy. So we really worked on setting really specific SMART goal plans around his weight loss plan for nutritional and physical activity changes, and really setting a 5 to 10% weight loss goal for him. And because of his persistent liver enzyme elevation, I chose to order a right upper quadrant ultrasound, which did reveal diffuse fatty deposition in the liver, suggestive of MASLD. So this obesity treatment pyramid is something I learned about from the Obesity Medicine Association. And it's a model that I find helpful. If you look on the left, when you're talking about potentially escalating treatment intensity, as BMI rises, we're more likely to see some of the complications that fat mass disease or some of the metabolic consequences of obesity. And when you might consider escalating therapy. So if you had a patient maybe with class 2 obesity and they really wanted to take this lifestyle approach as their mono treatment plan, they might not realistically get there with just enacting those changes. Now, they can still start there. They might not be ready for some of these other changes, but it's kind of a reference point for me as to where they might need to go in terms of their treatment plan. As you kind of escalate along this treatment pyramid, we see more percentage of weight loss with, most superior at this point in time being the bariatric procedures and surgeries.
And this is reflective of a continuum of care that we should be employing with our patients, that we should be initiating the lifestyle changes and perhaps even more intensive interventions, initiating pharmacotherapy, trying to optimize those before referring patients for surgery.
So at his next visit, he unfortunately gained another 7 pounds. And at this point, he was really frustrated because he had really leaned into these lifestyle changes. He was exercising at the gym 3 days per week. He had adopted a low carbohydrate diet and just wasn't making any progress. And at this point, he was much more open to considering alternative options to add on to his lifestyle changes. And his insurance did cover
Sorry. It doesn't show. Yeah, it doesn't
semaglutide for him. So we started him on 0.25 of semaglutide and started a plan to titrate up from there. So semaglutide has similar indications. Its dosing regimen is a little bit different than semaglutide used for type 2 diabetes. So you start at 0.25 and go up to either 1.7 or 2.4 for the maintenance dose. Its mechanism is through GLP-1 agonist, and it works by slowing down transient gastric emptying and increasing central satiety. And of course, we can see that it is quite efficacious. So over 50% of patients can have 15% or more weight loss. And a lot of the side effects are really GI related. And that's where I spend a bit of time counseling patients about how to handle starting this medication and really listening to their body's change in terms of that early satiety. So slowing down how fast they eat their meals and how much they're consuming during their meals. Because of that slowed gastric transit, if they eat too much or too fast, that's what's really going to drive a lot of that nausea, the acid reflux kind of symptoms. So what approach do you have in terms of starting?
So certainly prioritizing protein and vegetables in their diet becomes very important because they're eating a lot fewer nutrients and you want to optimize those nutrients that they're consuming. And then I have my 3 F's, not too fast, not too full, and not too much fat. So making sure that they're slowing down their eating, as you said, not eating too fast, not eating so they're so full that they feel nauseous, and a high fat diet will often cause nausea as well.
Ultimately, a lot of the counseling at that visit before we started semaglutide lived right here, where I was describing this negative energy balance state to the patient and all these physiological responses that he was fighting in terms of as he was enacting these lifestyle changes, now his body's responding by increasing hunger. It takes longer to get hungry and he's feeling less full. And that this was really not a failure on his part, that again, he's fighting these intense physiologic changes and that spring is pulling him back. And that is why we decided to escalate therapy. So at his next follow-up visit, he had lost 10 pounds from his peak weight along this journey, was tolerating semaglutide really well, and reporting reduced appetite, fewer nighttime snack cravings. And in the interim, since we've been developing this lecture, I saw him a couple weeks ago. He's now almost 30 pounds of weight loss. His liver function tests have completely reversed and are back to normal. And his dyslipidemia pattern has improved as well. So his HDL and triglycerides are now in a normal range, and his LDL is just still slightly elevated. At that point, he was on 0.5, and we were increasing him to 1.
Yeah, the question was he still on the 0.25 and you had titrated?
But I have had patients on 0.25 have such significant appetite suppression that we opted not to increase their dose. But for him, he's on 1.7 now. Yeah, I was seeing this patient in the middle of COVID. So my typical timeline for following this patient was a little bit staggered from what I typically would do. So I would have, Usually I'll try and see patients at least at 3-month intervals. I'm making changes no more frequently than every 4 weeks. So if it can work out that I'm seeing them monthly for a few appointments as we're titrating up, then great. But sometimes I'll have them titrate up on the medication as long as I know they're tolerating it well, and that we had enough time to kind of talk about escalation of therapy and when to maybe not take their dose if they're not tolerating it and things like that. So I might have them in between appointments escalate their therapy. Just depends on I think part of my being in a residency clinic kind of a setting, my continuity clinics can get spaced out a little bit as I take inpatient call and stuff.
But ideally, you like to see patients for every dose titration. I mean, that really would be best. Okay, so case 3, 15-year-old male with class 3 obesity, seasonal asthma, presents for obesity treatment. And just to get back to the question that came up earlier about how do you talk about obesity to a patient? How do you approach an adolescent patient about obesity? And it's a very sensitive topic, and you really need to be very gentle. And even if you're very gentle, it may not be received as well. Unfortunately, I've had stories of patients coming in and things being said to them. I had one patient who said that when she was 16, she was seeing an endocrinologist for her thyroid, and he said, you're fat and nobody's going to like you unless you lose weight. I mean, that was devastating for her. She went on to engage she lost weight through very unhealthy behaviors, engaged in high-risk activity to get people to accept her, and was really very devastating. Interestingly, she said when she was 18, she went back to that pediatric endocrinologist, told her how traumatic that was. He goes, well, it works, so I'm not going to change what I do. So probably not a DO, right? But it is a gentle topic that you need to talk about. And that's really where beginning with asking permission. Is this something you're okay to talk about with? And if they're not, to leave the door open. And what I say is, okay, I think it's important, and I'm here to help you if this is something you want to talk about. And if you want to talk about it at a future visit, just let me know. And so I think it's important to keep that door open and approach it in a sensitive way. I'm concerned about how your weight may be affecting your health or your future health. And that can kind of make it a little bit easier. But I've had many patients come in, and the first time they're tearful, they're reluctant to talk about it. But once they know that you're not going to be judgmental and stigmatizing towards them, in subsequent visits, they talk about it very freely. And when I see this patient and other pediatric patients, they're very willing to talk about it, and they don't have any hesitation. But it's breaking down those barriers is really important. So he had lost weight using a meal replacement plan, but gained it back. Going through his history, a lot of sugar-sweetened beverages, fast food, emotional factors for his eating, limited activity, limited sleep, too much screen time. Parents are divorced, so we have some adverse childhood experiences that are influencing it, and some underlying anxiety associated with this. So what would you focus on with this child?
Things that stick out to me here, having lost 35 pounds previously with the meal replacement plan is really impressive. I am definitely concerned about class 3 obesity in an adolescent patient. AAP, when they released their 23 guidelines on management of pediatric obesity, made a statement that patients that develop obesity in their adolescence overwhelmingly go on to struggle with obesity in adulthood and are more likely to develop early onset metabolic dysfunction. So I do get concerned certainly about a patient with class 3 obesity at that age. And then also some of the things in their history around sleep and physical activity and nutrition that might be contributing to their condition.
And so how do we diagnose obesity, and how do we classify it in children? We use the CDC scales for this, and this patient had a BMI of 43.9, which is the 99th percentile. But we look at, for classification purposes, where is it relative to the 95th percentile for children? And he's at 162% of the 95th percentile, which would put him in the class 3 range. Also has a very significant waist circumference at 53.5 inches. We did labs on him, and we can see here normal glucose, but high insulin level, and other metabolic parameters. Okay, what do you think about that insulin?
I mean, it's clear that his body is working incredibly hard to, with that being a fasting insulin, to maintain relatively normal glycemic control. Also concerned about prediabetes in a pediatric patient, and also his ALT, the cutoff for pediatrics being 25, under 25, his ALT being elevated makes me concerned for hepatic steatosis.
Right. So these are big factors. High insulin levels, I'll see those in kids that they have extremely high. They have young, healthy pancreases that can crank out loads of insulin. And so, yes, the sugar is 99, but that's a lot of insulin just to try to keep that blood sugar down. And we can see his A1C starting to creep up. And so one of the other things to think about in children that have extreme obesity in class 3 obesity is there a genetic cause for this? And there are genetic conditions that are associated with that cause obesity. There's a whole host of them, and you can do genetic testing. I used Rhythm Pharmaceuticals. They do this at no cost. They did a whole battery of genetic testing for different genes that are associated or cause obesity, and those came up negative. But you want to be thinking about it in a child that has very high BMIs. You have a high BMI at an early age, particularly age less than 5, if there's a strong family history of obesity, and if they have extreme hunger. So the Obesity Medicine Association has something called the Pediatric Obesity Algorithm that they publish. This is something that you can download in an ebook form. It is free to members and available to those who are non-members, but it breaks it up into those 4 different quadrants and those 4 different pillars of obesity treatment. So for this one, we were going to be focusing on screen time, which should be less than 1 to 2 hours, trying to increase his amount of sleep to the 10 to 12 that it should be, have him be more involved in peers. And this is a challenge for children with obesity because they're often bullied and shunned. Have him do some tracking of his meals and his activity. Increase having regular meals that are focused on protein and vegetables in his diet, working on getting rid of sugar-sweetened beverages, which he was willing to do, as well as cutting out fast food. Physical activity should be 60 to 90 minutes a day for this age group. And so incorporating some structured activity is beneficial. Metformin is something that's approved for diabetes in children 10 and above. And then semaglutide, liraglutide, and phentermine, topiramate extended release are approved for age 12 and above. And so for our plan here, we took a comprehensive approach, increasing protein and vegetables in his diet, healthy snacks, replacing the sugar-sweetened beverage with water, and cutting out fast food. He lived across the street from his cousin, so he was going to play with his cousin an hour every day. It was a dedicated time, but also track his activity with a Fitbit. Emotional eating was a factor for him. He has an anxiety disorder, and he was really struggling with that. And also dealing with boredom. He would just eat and play video games. So trying to increase that activity. We put him on metformin initially, and then I added the topiramate phentermine combination. And he too qualifies for surgery. So that's something to consider based on his BMI and percentiles. So this is the medications that are approved for obesity in pediatric population. Phentermine can be started at age 17. Orlistat, phentermine, topiramate, liraglutide, semaglutide are all that start at 12. But you may not recognize setmelanotide. Setmelanotide is a medication that is for specific genetic disorders. So there are specific genetic conditions that this medication is indicated for. It can be beneficial for helping patients helping children and adults with obesity. And so there's also specific codes for pediatrics. So I included that in the lecture because I thought it would be helpful to refer to. There's class 1, class 2, class 3 obesity, which has the same E codes, but there are different Z codes that go along with that. And again, you can get the charts for this through the CDC. So just to follow up, this is a challenging case. He he continued to gain weight. He lost for a little while, continued to gain weight on metformin and phentermine topiramate, as well as phentermine alone. Semaglutide would be ideal for him, especially with the high insulin level, to protect his pancreas and reduce some of that pancreatic stress, but denied by insurance. I wanted to refer him for counseling. He wasn't ready to do that. His parents weren't ready for him to do that either. We talked about a tertiary center referral for bariatric surgery, but he was not ready for that either. But he did say that he was at school. He joined a club that was a weightlifting club that was being put on by a teacher, and he was going to start doing weightlifting and increasing his aerobic activity. He was still very determined to improve his diet, and he actually did make a lot of dietary improvements. He decided at this point he didn't want to take medication anymore. But that's where we're at. This is a reflection. Not everything's a home run, right? We don't want to just show home runs. This is real world challenges that we face, but we'll continue to work with him. What I do appreciate is he keeps coming back, right? And he keeps coming back because he's not being judged and not being stigmatized and not being made to feel bad about how he was doing. All right, so now we have I think 7 minutes for some questions. So we'll go ahead and do that. There's another case on a condition called lipedema. I'd encourage you to look that over. That is something that you're going to see in your practice. It's a condition where women get excessive amounts of weights in the lower part of their body, and that can be very painful and difficult to treat because it's very resistant to dietary interventions. But that's something to look over. Question.
2 questions. One of them is on the phentermine and topiramate. Phentermine is often prescribed on its own, not as the combo because it's cheaper. Can you comment on topiramate by itself or separately prescribed from phentermine as 2 different medicines together? That's one question. And the other one, is there a role for the central nervous system stimulants that are used to treat ADHD that have the side effect of appetite suppression? And I'm almost hesitant to ask that because it's hard enough to get those medications in the hands of actual ADHD patients, even though they're safe. But, I'm kind of surprised there's no research on that. Why is that not done?
So, just just regarding the topiramate, it is very inexpensive. The first patient I had prescribed phentermine and topiramate separately because the combination wasn't covered. For this child, it was covered, so I used that, and I would use that in an adolescent, because phentermine by itself is not approved for less than 17. So I tend not to opt for that. But the combination is relatively cheap, and I like to prescribe the phentermine in the morning and the topiramate in the evening, because topiramate can have some cognitive effects, that some word finding issues and some cognitive slowing that can sometimes happen, not everybody, but then if they take it in the evening, it tends to be less of an effect. And it also helps more with nighttime eating, so I find it beneficial. And it often helps with sleep, especially patients with chronic pain. So I'll use it in that scenario. Interestingly, I've had many a patient tell me that, yes, the phentermine is helping with my appetite, but boy, I am really focused and able to get things done. And so that stimulant effect, actually, it's not approved for ADHD, but I find a lot of people that maybe had it or didn't know that they had it, find that their focus and concentration is much better. I haven't seen any studies on using phentermine and ADHD, and it's been a generic for so long and so cheap, nobody's going to spend the money on the studies. But anecdotally, I do find that.
And to your first question, I haven't used topiramate as a monotherapy for obesity, but I have used it, like, kind of thinking from those previous slides of like when I might choose one medication over another. So take chronic migraines, for example, I'm more likely to lean towards topiramate to help with controlling chronic migraines and as a prophylactic medication over propranolol if I'm worried about weight in that individual.
And I have used it as monotherapy, but particularly, there's data showing that patients that have had bariatric surgery, particularly Roux-en-Y bypass, do well with topiramate to help lose weight if they're regaining. I think there's a question over there.
And the second part of her question with ADHD, like methylphenidate.
Oh, using it with it. Yeah. So in terms of using those medications for ADHD, that they do suppress appetite. Sometimes it's a problem, even too much appetite suppression. When I have a patient on it, I won't put them on on phentermine at the same time, but I have added topiramate to that.
Okay. Hi, I had two questions too. The first one is if you have someone on a GLP-1, either you plan on stopping it either because they've plateaued, or another one is they can't afford it and they wanted to kind of kickstart like a bridge into lifestyle management. How would you stop it? Would you stop it completely or just taper them off? And then the other one is getting the fasting insulin covered by insurance. Is that just like dyslipidemia? Would that get it covered, or what else would you put it?
All right, I'll take the first one and take the second one. For the GLP-1s, I don't endorse the idea of jump-starting somebody with a medication, because that really goes against the physiology, right? Because the physiology says that as you're losing weight, you need the medication more, not less, because hunger is going to go up as your weight goes down. If you have to stop the GLP-1s, if you can titrate it and see if they can do better on a lower dose, I've done that, but it doesn't really make sense from a financial point of view since each dose costs the same as the other. So you're not saving any money there. What I have done sometimes is extend the dosing more than a week. Some patients can go 10, even 14 days between doses, and that has made it more cost effective. So that is something that I've done in patients as long as it satisfies their appetite for that amount of time. But if you have to stop it, you can just stop it. There's no kind of withdrawal or difficulty with doing that.
To your second question, if I put hyperglycemia, metabolic syndrome, insulin resistance, any of those codes, I've been successful with getting that covered. I usually will quote, for our lab, I think it's $50, so I will quote it to the patient, but I've never had a patient that didn't get it covered by their insurance. And then I have had a couple instances where I submitted a prior auth for a GLP-1 with an elevated fasting insulin, and they've gotten it covered with that. Their insurance originally said they would only cover it for type 2 diabetes, and I submitted that, and they covered it.
All right, one last question.
So in the state I practice in, the state Medicaid system is very strict about who they'll cover the GLP-1 agonists for if they don't have diabetes. So a couple of my patients have found sort of compounding pharmacies that will make some form of semaglutide. I'm not, with weird dosings and, weird formulations. Do you have any experience with them? And do I have any reason to be kind of worried about those sources? They're all in the U.S., so I assume they're legal of sorts.
Well, they're not made in the U.S., right? And they're not made by the manufacturer. So the compounded versions are made by other manufacturers that are essentially bootlegging that compound to sell it. It comes in all these crazy forms. We get patients that get their syringes wrapped in tin foil and sent to them, and just kind of really weird. There's GLP-1 patches and sublingual, and none of it is evidence-based. None of it is proven. But I think there are certain compounding pharmacies that were able to compound these medications through sort of legitimate sources, and they would do independent testing. So there were some good compounding sources for that. The question is now the FDA has said the shortage is over, because that was the reason why they could do it, because there was a shortage of compounding medications, or of the brand name medications, so pharmacies were allowed to compound them. But that is going to, at least the legitimate market is going to be shut down for that. Okay. We're out of time. Thank you so much for your attention.